Guys, welcome back to another guide revision video, and today we'll be covering part 1 of the pulmonology section. So in this try to keep it really short and simple because these are the topics that usually a lot of the students are going to mess up or confuse between them. So the topics in chapter 5 are going to be pneumonia, asthma, COPD, URTI and acute severe asthma, and the reasons why we get acute severe asthma. And starting off with pneumonia is going to be very important, not just the treatment, but they may also ask what are the most common organisms in different settings, and we'll be going over those as well. I try to keep this chapter pretty short because there's a lot to memorize in this, especially for the organisms and the treatment ladder for asthma and for COPD and what would be the difference between those two. Then for URTI, what could be the organisms and how do we treat them and when is the treatment done. And for acute severe asthma, what does that mean? And how, what are the indications for the treatment for this. Now, this is chapter 5. In chapter 6, which is the next video, we are going to be talking about pulmonary embolism and DVT. So it's well score CTPA versus VQ scans, anticoagulation, massive PE and thrombolysis, but this is that comes later on. All right, now to start off with pneumonia, we have first we'll be discussing community acquired pneumonia. And according to John Murtagh on CAP organisms, so Mycoplasma pneumonia as the most commonest atypical pneumonia. Just remember that the most common atypical pneumonia is Mycoplasma pneumonia. It affects the age group, which is adolescents and young adults. And then we have Legionella pneumophilia, which is related to cooling systems. So if a patient comes to you that is working on HVAC systems or AC systems, and they suddenly develop pneumonia, this is usually Legionella pneumophilia. Incubation period is 2 to 10 days, and they will have in the prodromal phase with influenza-like illness with dry cough, confusion or diarrhea with very high fever and hyponatremia. And the antibiotic treatment for mild pneumonia is always going to be amoxicillin hourly for 5 to 7 days plus doxycycline if atypical is suspected. However, if they have allergy to amoxicillin, we can move on to ceftriaxone or other drugs. And in severe pneumonia, we give ceftriaxone IV because it's severe, daily plus azithromycin. So this is just a short summary. We'll be going over the whole important factors one by one. So the first one is the classification, which is the CURB 65. So what does the patient present with, right? So CURB, where the C stands for acute confusion, new disorientation to person, place or time. Then urea more than 7 millimole per liter, the score is 1 and reflects systemic illness severity. All right, respiratory rate more than 30 per minute. Now this is very important because in a lot of the scenarios you have to also see what is the presentation of the patient, right? If they have tachycardia, what could be the reason for this high respiratory rate? Do they have any underlying diseases? If they already had asthma in the past, do they have bronchoconstriction? But based on the history plus doing the CURB 65 score, we have to assess the respiratory rate as well. So sign of respiratory compromise would be respiratory rate more than 30 per minute. Blood pressure less than 90 systolic or less than 16 diastolic. It's again one score. So hemodynamic compromise. Then age more than 65 because it's CURB 65. 65 is the age. So age related increased mortality. All right. Now if the score is 0 to 1, which is low risk, then we have outpatient treatment. If it's going to be 2, then we have hospital admission or close monitoring. 3 or more is going to be hospital admission plus consider ICU if the score goes to 4 to 5. All right. Now moving on to the important organisms, this table is very, very important. I've seen questions very, very commonly about this, that they'll give us key features. I've taken these from Murtagh, and then they will ask you what could be the most common organism, or they could give you the features that ask you how do you treat this organism, right? So this whole table is very, very high yield. All right, so the organism for Streptococcus pneumonia, which is most common. So most common is the one that's most frequently seen. So if they don't have any other, occupational history, like for example, HVAC system worker or patient who had been in the ICU or the hospital for the last 3-4 days, then we consider Streptococcus pneumonia. And this will see rusty colored sputum, rapid onset, right? Rigors, pleuritic chest pain, and focal consolidations on chest X-ray with leukocytosis. For the treatment of this, we give amoxicillin, benzalpenicillin, or ceftriaxone IV. All right. If they have allergy to penicillin, we move on to ceftriaxone. Then Mycoplasma pneumonia, which is atypical, as you read above. In this, we see those in young adults and adolescents. The important fact is that they have fevers without chills. all right, and they have non-productive cough. Chest X-ray worse than clinical signs. All right, we see cold agglutinins for these patients as well. So how do we treat them? We give them roxithromycin, all right, or doxycycline, 100 mg twice daily for 14 days. Then moving on to Legionella pneumophilia, cooling towers, air conditioning with dry cough, confusion, diarrhea. Now diarrhea is an important factor because it's if you don't know that this is pneumonia, a lot of differentials can come to mind because of that. All right, they have high fever, hyponatremia, and relative bradycardia. And the treatment of choice is going to be azithromycin IV first line, and we add ciprofloxacin if the patient is still severe. Then chlamydia pneumonia, it's similar to mycoplasma, biphasic illness in young adults. For this, we give doxycycline or roxithromycin. Then Staphylococcus aureus, it's post-influenza pneumonia. All right, we see cavitating pneumonia on chest X-ray, mostly seen in IV drug users and ICU patients. For this, we use flucloxacillin IV, which is, and we add a ceftriaxone for severe CAP. All right, then Klebsiella pneumonia, we see these in alcoholics, elderly with, so this is an important point, with current jelly sputum. In the upper lobe, we see consolidations, and then they'll have aspirations as well. And the treatment is going to be IV cephalosporins plus aminoglycosides. So this is different because we're using aminoglycosides for Klebsiella pneumonia. All right. Now, we have to remember all of the differences between these different organisms, because knowing the organism is going to lead how do we treat this patient and what option do we go with. Because if we go with the right option, right treatment, the patient is going to get better, and obviously we'll also get the right answer, which means we get a mark for that. So those two facts are very important. So just try to memorize this table a lot. Just what I usually do for things that I need to memorize, I write them down or pin them out and then just put it on a table that I look at every single day. And day by day I memorize 1 or 2 points, and that sticks. Now, according to the CORB score, which is the equivalent of CREB 65 for Australia, confusion, hypoxia is SpO2 less than 90%. Respiratory rate, again, same, more than 30, BP less than 90 by 60. So CORB score of more than 2 as indication for hospital admission. And AMC may use either CREB 65 or CORB, so we need to know both of them. Now, going back to CREB 65, remember that for 2, it's hospital admission or just close monitoring. Whereas for CORB, for more than 2, we have to admit them to the hospital. All right, now that was for pneumonia, all the important high yield parts. Obviously there will be x-rays and different things that you can see, but if you memorize these points, I believe that, even I can answer MCQs based on the history of the patient that they give, and x-rays are just going to add on to those points. All right, now moving on to asthma. So moving on to asthma is that about what John Murtagh says, that 1 adult in 8 has had asthma. The focus of management should be on prevention. An acute asthmatic attack represents failed treatment. All right. Inhaled corticosteroids are the cornerstone of asthma treatment. Avoid concomitant medication that may exacerbate asthma, such as beta blockers. So beta blockers are contraindicated in asthmatics. Aspirin, we don't give them. NSAIDs, we don't. Then preventer concept is that treatment with a preventer is recommended if the asthma episodes are more than 3 times per week, or those who use SABA more than 3 times per week. And absence of wheeze is in a breathless person is a serious sign, because that means that the asthma is exacerbating even more, and there are no more wheezing because the space has become so constricted. All right, so it's a red flag basically. Now the asthma classification, again, it's very important because based on the classification we have the different treatments for them. All right, now this is a very simplified table. You can memorize this again. So most of the tables and most of the text in this on my guidebooks are very, very high yield, and if you can memorize those facts, those are covering majority of those topics and majority of the questions that will be asked. All right, so in severity we have intermittent. What does intermittent mean? So there is less than 1 episodes per week, and night symptoms are less than 2 times per month. So the differentiation is that these symptoms are considered both in the nighttime and per week time. So less than 1 time per week or less than 2 times per month is intermittent. And FeV1 by PEFR ratio is going to be more than 80%. All right, and in this step-up treatment management, we only give SABA, PRN only, and no regular preventer is used unless this SABA is being used for more than 3 times per week. Remember this, more than 3 times per week. And there are questions where we have patients that are already on SABA, but the patient complains that they have the symptoms even while they're doing some exercise or playing some sports. So the treatment for that would be to use SABA right before they engage on those activities. All right. Now moving on to mild persistent. Mild persistent is more than 1 symptoms per week and not daily. All right. And night symptoms are more than 2 times per month. And FEV1 by PEFR is always going to be more than 80% or equal to in these patients as well. In this, you have to add a low dose ICS, such as beclomethasone less than 250 mcg per day, or budesonide. All right. So we are adding to them. All right. So now moving on to moderate persistent. So they have daily symptoms now. Night symptoms are still less than once per week. Night symptoms are more than one time per week, and exercise is limited in these patients. The ratio is going to be 60 to 80%, and this we have to give them an ICS and LABA combination, all right, plus the SABA PRN that we discussed. And the the combinations that are available are Symbicort or Seretide, and these could be given in the options. So just remember these names as well, other than the drug classes. Now, the severe persistent is going to be continuous symptoms, frequent night symptoms, and severe exercise limitation. In moderate persistent, we have more than once per week night symptoms, but in severe persistent, we're going to have frequent night symptoms, so more than once per week. Then the ratio is going to be less than 60%. We have now to give them a high dose ICS plus LABA, plus consider add-on Montelukast, omalizumab, and oral steroids at this point. All right. Moving on to the triggers for asthma, the mnemonic is A, B, C, D, F, G, H, I, J. A is for allergens, B for bronchial infection, C for cold air and cold air while exercising, D is for drugs. Drugs, I've seen the drugs being mentioned. So it's important that you can if you can memorize these drugs, and these are very simple drugs, just 3 important ones: aspirins, NSAIDs, and beta blockers. E is for emotions and stress, food, sulfites, seafoods, nuts, and MSG. Nuts is important because it can also lead to anaphylaxis, and anaphylaxis with shock could also be confused with, so anaphylaxis can lead to respiratory depression that could be confused with asthma as well sometimes. Then GERD, hormones such as in pregnancy and menstruation. I for irritants, and G for jaw because of occupational asthma, or for wood, dust, floor, and isocyanates. And job is also important because we have also sarcoidosis and pneumoconiosis that we'll be covering up later on. So those are important points that occupation is going to play in this patient. And as we read in pneumonia up above, that if they're working with cooling systems, you have to keep Legionella in our mind as well for pneumonia for those patients. Now, moving on to acute severe asthma, life-threatening feature. So acute severe asthma, and what are those features? Is that SpO2 is going to be less than 92%. PEF is going to be 50% of predicted or best. Silent chest where there is no wheeze, all right? Complete obstruction. So it's a red flag. Respiratory rate, again, more than 30. Heart rate more than 120. Unable to complete sentences. Altered consciousness with cyanosis. So they'll give you patients that have they won't tell you all of these symptoms, but they may say 1 or 2 of them. So they would say that this person can only speak in words and can't complete sentences. The management for them is going to be high flow oxygen with the target SpO2 between 94 to 98%. And then we have to give them salbutamol through the nebulizer and not through the puffs that we use, and we have to give this continuously. Then we give them ipratropium, and this is an important management because I've seen at least 2-3 questions based on these from the past recalls. All right, they'll give you 1 or 2 from those management and ask you what's next or what's the best management for them. So you have to mention all, choose for the option that has all of these stated. Then ipratropium 500 mcg nebulized, IV oral prednisolone, or IV or oral depending on the condition of the patient. Then consider IV MgSO4 2 grams over 20 minutes, and if they start deteriorating, we have to get them into the ICU. The criteria for intubation is going to be exhaustion, silent chest, again that's a red flag, all right, failing or falling SpO2, rising PaCO2, and altered GCS scale, all right. Again, drive this point home that never give beta blockers in asthma. Even topical ophthalmic beta blockers can cause fatal bronchospasm. And we never use LABA as a monotherapy without ICS. So if you give them an ICS, so if you give them LABA, we have to add an ICS to it, all right? The reason for that is that it increases the risk of asthmatic deaths. All right. Now moving on to the next topic, which is COPD. Now COPD, according to the Murtagh, the definition is that it's a non-fully reversible persistent airflow limitation that are usually progressive and associated with an enhanced chronic inflammatory response in the airway and the lung to noxious particles or gases. And spirometry for after post bronchodilator FEV1 and FVC ratio is going to be less than 0.7 or less than 70%. And this is required for diagnosis. Long-term oxygen therapy, it reduces mortality in COPD, and continuous therapy for at least 15 hours a day prolongs life in hypoxemic patients. Those who have PaO2 consistently of less than 55 mmHg or SpO2 88% at breathing air. All right, we have to give them LTO2. And smoking, the only treatment proven to slow the progression of COPD is smoking cessation. So, keeping in mind is that COPD is a very later in life disease, especially with patients who have had a smoking history. So the age of onset, so not to differentiate between asthma and COPD because both of them have obstructive patterns. So COPD is going to be more than, the age is more than 45 and peaks at 5th and 6th decade, whereas asthma is more childhood centered. Causes for asthma are atopic genetic triggers. COPD is usually cigarette smoking. All right. Reversibility, asthma is fully reversible and gives more than 15% improvement in FEV1. COPD is partially reversible and gives the ratio is less than 70%. All right. Spirometry, FEV1 by FVC is less than 0.7 and reverses with SABA, whereas FEV1 by FVC is less than 0.7, but even after post bronchodilators, it doesn't change much. DLCO is normal in this, whereas in COPD it's reduced because of alveolar destruction. Then sputum eosinophils, it's yes, because asthma it's more immune centered, whereas COPD is going to be predominantly neutrophilic. Right, and not eosinophils. Alpha antitrypsin deficiency, it's related, but for COPD it's not. So for asthma it's not related, whereas for COPD it's associated, especially in young onset emphysema or in non-smokers. And ICS for asthma is the cornerstone of treatment, whereas for COPD it's only 10% are going to benefit from ICS monotherapy. Then prognosis of asthma is really well if they have they stick to their medications and are compliant with it. Whereas for COPD, either way, it's going to progress. Even whatever treatment we have, it will progress and get worse. All right, that's all it progresses. Then COPD's management plan is going to be COPD-X. All right, now that's the mnemonic COPD-X. So C is going to be confirming the diagnosis with bronchodilation. And the severity for mild FEV1 is more than 60%, moderate is 40 to 59, and severe is less than 40%. All right. Now O is optimized function, so we give them bronchodilators plus so SABA, then LABA or LAMAs. So we have SABA, which is short acting, and then long acting we have tiotropium, which is a LAMA. And they have started asking LAMA more now, whereas before in the past, I think 2 or 3 years ago, they didn't used to ask about LAMAs, but now they start asking about LABA. And there's something called the triple therapy where we also add ICS, LABA, LAMA for FEV1, which is less than 50% with frequent exacerbations. All right. So less than 50% means that it's between moderate. So we have triple therapy for that. Prevent deterioration would be ceasing smoking cessation and vaccinations. Because of their buildup of fluid in their lungs are more moist and they're more susceptible to getting influenza. And if they get influenza, their SpO2 is going to deteriorate more. So we have to give them annual influenza vaccines plus 5-year pneumococcal vaccines. Smoking cessation, only proven disease modifying intervention. All right, is the only intervention that helps improve the disease, and this has been proved. Then D is to develop a support plan, which is pulmonary rehab, such as breathing exercises, aerobic training, occupational therapy, dietitian, psychologist. X would be to manage exacerbation. So SABA plus ipratropium plus oral prednisolone plus antibiotics. So 4 drugs in this. All right. So prednisolone would be a 5-day course, whereas the O2 has to be controlled at 28% Venturi or 2 liters per minute to avoid hypercapnia. All right. Now, long-term oxygen therapy, the indication for LTOT is the criteria. The PaO2 has to be consistently less than 55 mmHg, or SpO2 has to be less than 88%, or PaO2 has to be between 55 and 59 mmHg, or core per milliliter, or with they have polycythemia vera as well. All right, and minimal daily duration should be at least 15 to 18 hours per day, and 15 hours as close as possible to 24 hours. Then the preconditions for LTO2 is the disease is stable, plus they have ceased smoking for more than 1 month previously. So one more than 1 month before the LTOT has been started. Flow rate for it is going to be 0.5 to 2 liters per minute to maintain resting PO2 at 60 mmHg, and we shouldn't let this PO2 increase or the PaCO2 decrease, because the way that the COPD patient works is that their lung and their body is more used to having hypercapnia, and if you introduce a lot of oxygen to them, that means that the respiration is going to drop down below, because it's not dependent on hypoxia. All right, so it's going to be we can't give them high flow oxygen continuously, because for COPD patients, they are dependent on the oxygen concentration in the blood. So if the oxygen concentration in the blood is going to suddenly increase, that means the respiration is going to drop, and that means we can't get the already carbon dioxide that's in their blood to for them to exhale it out, to excrete it basically. Then high flow O2 is dangerous. Again, my point is being explained in the next point here, that it can cause hypercapnia in CO2 retainers. All right, so we have to always use control O2 and target an SpO2 of 88 to 92%. All right, so that was all of the important facts for COPD and where they could give you questions from. There are other facts as well, so the what the symptoms would be for patients, but these are, I think, basic information that I've not included in the guidebook. But later on, when I get the time for it, I'll make in-depth videos of every single topic for you for completely free, and you guys can watch that and get all of the important information as well. Now, coming up to the upper respiratory tract infections, so these are the ones that are most commonly asked, especially this crop. Crop was one of the most famous questions in the March recall. So if you can memorize this, then excellent, we'll get those marks. So common cold is caused by, most common is rhinovirus. The symptoms are going to be sore throat, malaise, no fever usually. And symptomatic, we have to give them paracetamol, decongestants, honey, and we don't give them antibiotics. All right. Influenza is going to have an abrupt onset with a very high fever, myalgia with prostration, and systemic respiratory symptoms. So systemic symptoms are going to be a lot more than the respiratory symptoms. Then the treatment is going to be oseltamivir or Tamiflu within 48 hours in high risk. We have to also give them paracetamol to control the fever and body aches because they have myalgia. And we give them antibiotics only for secondary bacterial pneumonia. All right, now moving on to acute sinusitis. The patient is going to have facial pain because you can feel sinuses, and they'll have facial pain because of those sinuses being inflamed. They're going to have pressure plus nasal discharge for more than 10 days or even severe. For this, we do saline irrigation, analgesics plus amoxicillin if the acute sinusitis persists for more than 10 days or becomes severe, right? And there's no improvement in it. Now, pharyngitis, it is modified Cento score. So fever, no cough, tender anterior cervical lymph nodes, and then we have tonsillar exudates. All right, and the drugs we use is amoxicillin or phenoxymethylpenicillin. If Cento is more than 3, that means that group A strep is more likely to be the one that's present. All right, for GAS, it is going to prevent rheumatic fever. That's when we give them. The group A streptococcus is when we give them antibiotics so that it prevents rheumatic fever from occurring. Then epiglottitis, it is toxic, drooling, stridor, tripod posture, and rapid deterioration. So these are the symptoms that I've seen in exam myself. So drooling and tripod posture with rapid deterioration. We do not do anything in epiglottitis. It's an emergency. We have to do, they ask you what to do. We keep the patient calm and we call the ENT and we give them anesthetics, and the ENT is going to prescribe those, but that's what we do, keep them calm, anesthetics and IV ceftriaxone, right? And antibiotics, yes, ceftriaxone IV immediately. Now crop, the most common is going to be barking cough with inspiratory stridor. And we usually see them in 6 months to 3 year patients. And we have to just give them a single dose of oral dexamethasone. Adrenal nebulization if the condition becomes severe. Again, no antibiotics. All right. So these were all the important topics from our today's topic. So we covered asthma, We covered COPD, we covered acute asthma exacerbation and emergency, we covered pneumonia and the different organisms, we covered URTI, the most common ones that I saw recently. And these are all of the worked AMC questions from the topics from today, and they are based on how the MCQs were presented in the March and February calls for 2026. So just go over it and see if you can answer them. If you can't, then just go back to the topic and revise it once more and then continue it. All right, because it has the answer plus the explanation of the answer as well. So I think that should be really helpful. If you guys have any recommendations, you guys can drop a comment down below. And if you have any questions, drop that down as well. And soon I'll also be starting a Telegram group so that you can share it around and people can join easier on that. So check out the WhatsApp group. The link for this is going to be in the description. It's going to be it's pinned in the comment section. So if you guys want to download it, if you guys want to just view it, it's on my Google Drive, and the link is going to be in the pinned comments in the section. All right then, thank you.